All right. Thank you very much again for coming and being here. We really appreciate your time, and it's been a great discussion. Um, we heard some great talks, and I think, in the stroke care, we have come a long way. I mean, if you think of it, before 1995, we didn't really have acute stroke care, and then after 1995, we started having IVTPA. It took us another 20 years to get to thrombectomy as a proven therapy, and now we are where we are. Is we're trying to expand the borders. What is how big is too big? How small is too small clot? So it's been a great journey, but system of care is really becoming the most important topic now. So I think the conversation here is, well, now that we have such great effective therapy available, what can we do better to improve this care and expand it to more people like Shank and other people that we share. So I would like to just open this and start having this conversation as to how we can improve the system of care and go from there.
Sure. I got one on there. Go ahead, Mike. Oh, I would say from my perspective, we need to take away what I consider to be the false argument between whether you should go to primary or comprehensive. And I think the reason why the argument exists is because stroke is still an immature system. Nobody ever suggests that when you take a trauma patient to a trauma center and they do not do surgery on them, that you therefore brought them to the wrong place. And I think we have this false argument in stroke because I hear, well, you brought them to a comprehensive stroke center and they didn't do brain cat. There's no Monday morning quarterbacking in healthcare. And for all these scales that we have pre-hospital, not one of them is 100% accurate. Who wants to volunteer to be the one that I bring to the wrong place? I don't. In which case, Palm Beach County, if you have a stroke, or we think you have a stroke, you're going to a comprehensive because the data shows that's the best outcome. So I think once we move to that mindset and we start increasing the resources so that EMS can get to these centers in a timely manner and try to do so without a focus on business, but a focus on spreading the care in a rational way like we do trauma centers, then I think we'll be improving the care.
But I'm with you on that. But the only thing that I get asked all the time is, if a fire is, or there's another car accident and my rig is too far from our station, we're going to delay our times, So it's a struggle because each region that's close to my house, that's their reason to bring closer, and I struggle with that too, because I understand the problem, so I think that that's why we kind of went the approach that we're going. But I want to be sensitive that our emergency services are also trained to try to deliver care for other things that they call. So how we take care of that,
Well, I'll tell you, it's more of a strain when we get called to do a second transport than to just drive a little further the first time.
Well, no, but then our proposal is totally independent, and the regions, the EMS system takes care of the region. It will be a separate, the hospital is an independent, is the network responsibility to get that done then.
Each region's different. EMS, there's a saying in EMS that if you know one EMS system, you know one EMS system because there's so much variability.
Yeah.
And I can tell you in our area, there's the resources set up to do the interfacility often ends up falling on the 911 system.
Is that right? Okay.
Absolutely. And that's not necessarily true everywhere, but that is true.
I see. Well, I can, Danny doesn't help you at all, but I'm just thinking so that's one thought, is just to try to keep the rig so that the times are reasonable for any type of emergency, but then we have to develop another layer that would be for that.
I have just a question. Can you present on that? It sounds to me that South Florida, specifically, if you have any stroke, not just beyond TPA window, any stroke, you're going to the comprehensive.
That's correct. Assuming we recognize it's a stroke, right? So that we will take strokes that we don't realize are strokes to non-comprehensive centers. But if EMS suspects you're having a stroke, there's one and only one level. We go to comprehensive. And if you're out in the rural areas, we fly you to the comprehensive.
Because what Charlie showed, and I know I want Brad to comment on that, but Charlie showed our Florida form, and we're still on that. If you're TPA, go to the closest candidate, go to the closest TPA giver. And I know we've gone a long way in Jacksonville, bypassing primary, going to comprehensive, and we see this on numbers. But what is our attitude in Duval County, Brad, with the Florida form? What we're doing in Duval?
So overall, I think we are fairly biased towards the comprehensives. There's really a tight window for a primary stroke center to be the destination. Typically, it's got to be geography, onset less than 2 hours, with a LAMS of 1, 2, or 3. That's really the window at which a patient could go to a primary. For the past 4 years, we've trended strokes. 4 years ago, actually more patients went to primary stroke centers than comprehensives. As of last year, 83% of our stroke alerts went to a comprehensive. So we are in the process of changing that culture, again, kind of driving patients to comprehensives. But yet, I do think there is an opportunity for some patients to be brought to a primary center at this point. We've also seen trends in just general stroke care. Over the past 4 years, we've seen a steady growth, 15% on average each year of stroke alerts. And that's in comparison to our overall EMS volume of 2% growth a year. So we're clearly seeing a diversion, be it greater awareness, be it on the part of the stroke centers and the public, be it awareness on our level with greater training and emphasis on stroke care. So we're definitely seeing stroke alerts being called at a greater rate. They do kind of fall in that about 1.2% of our overall volume. We transport approximately 83,000 patients a year with roughly 964 stroke alerts. But again, with about 83% of those as of last year going to a comprehensive.
How many, you mentioned something that I'm very curious. What do you think is the best way to train your team? Like what has been the most effective way to identify stroke? Because first of all, maybe the number of people that you have to train, and what is the best method at this point?
So for us, we're a large agency. I have probably 1,200 uniformed personnel.
Mm-hmm.
So a training which we just completed last year. That last year, stroke was one of my priorities, along with airway. So we put every rescue officer, and we're also talking to the suppression teams, putting them through it took about approximately 8 months.
So it's an immersion, like you do lectures, they
yes,
go to
so we'll take a unit out of service, bring them to training academy. It's about a 4-hour block, combination airway and stroke training, didactics, case studies, kind of case presentation, and with a kind of a question, should the patient go to primary or comprehensive stroke center with various.
And you do that, you recertify yearly or 6 months, or it depends on the number of.
With our, this will probably be a every 2 years.
Okay.
Kind of operation.
I see. And it doesn't matter how many stroke trips. If somebody has had a stroke for 6 months, which may be hard, but do you have visibility of that, or how many runs the team is deploying that knowledge, or is there a way to do this more often to assure that everybody's sharp?
We probably need to delve into the data on that.
Okay, good. So there's an opening for that, right?
There is.
Good.
The question I have is going back to what we talked about earlier. Triaging to comprehensive center versus primary is an interesting topic, but we all know that there's a comprehensive center and there's a comprehensive center. In Southeast Florida, what do you guys do? Let's say if you take a patient to just a comprehensive center X, it takes them 90 minutes to an hour, 20 minutes to get a groin puncture because of the availability or the resources. Where you take a patient to hospital Y, where it may be about 20 minutes further, but they're very efficient, and it takes about 40 minutes to get the blood vessel opened up. So what do you do there to decide, okay, there's a comprehensive and there's comprehensive, and how do you manage the triage from that regard?
You're absolutely right. And like I was saying before when I was up here speaking, is that was sort of the impetus for the birth of the Florida Stroke Registry. is because we were looking at, you know, we're bringing these people past closer hospitals to go to a comprehensive. How do we know you're doing a good job? It's and we take this very seriously. It's my responsibility for 1.5 million citizens to bring you to the right place. So I have to, since there's no third-party verification, I'm going to have to do that third-party verification myself. So we use the Florida Stroke Registry right now to allow the hospitals to see how they are compared to their peers, with the hope that they can see, well, this is where I am and this is where everybody else is. And it's still blinded right now. I mean, the EMS medical director can see who each is, but the hospitals don't know who, they just know who theirs are. They can see the rest of them. So it becomes a good internal CQI tool. We're not using this to bash people over the head. We want the resources out there. We just want everybody to share the best practices. So we have two things. We have that, and we have our local, we call it the Gulfstream Stroke Coalition, where all the stroke centers get together, primary and comprehensive, and they share best practices. They talk about EMS bypassing the ER, going straight to the CAT scan, some of the things we heard about here today, and some of these other innovations. And we share that freely, understanding that this is not something to develop market share, because honestly, patients don't know what you do inside your hospitals. They have no idea that you got a groin puncture of X and they got a groin puncture of Y. So we really should all share that so that it improves care for everybody.
Now, do you then change the destination if you have two comprehensives with a greater time at one?
So that was part of the fear of the hospitals giving that data. They were worried that EMS would do that. Mm-hmm. We have not been using it for that. So right now we're using it so that the hospitals can improve themselves. But this is still new in the process. So if, let's say it's a couple of years have gone by and you are still the lowest by far, a couple standard deviations away outlier, and you've shown that you are either unwilling or unable to improve, what would you want me to do? I'm the EMS medical director. You're in the back of my truck. Where do you want me to take you? So I think we have some responsibility to the public, to ourselves, and to healthcare in general, to encourage everybody to improve. And if you can't improve, then we really have to take you to the right place. It's all about going to the right place. But we're not, that's maybe something down the road. I'm hopeful that everybody will just improve on their own, not to see the data.
Sorry, I think when British and Niels and you guys designed this, the idea was to keep the light off for a while and then turn the light on. So the right. A, B, C, D, E would be named A, B, C. Have you turned the light on so people can see what it is? What?
Yeah, you're absolutely right. So the initial agreement is that we would wait at least a year. But there was a couple of fits and starts in terms of deciding which data elements we're going to get, who's got their data turned on. So that clock had not started running yet. So we're just now finally getting to the point where we're getting routine data to the hospitals.
But so we can learn from your model. So do you give Baptist a reporter here? This is Baptist, your letter C on this line. Those are your numbers. Those are your competitors. So we can learn, because we did this with the strategy that was beautiful. You get national average, study average, and your numbers. So you can compare, look, I'm better than average, but I'm worse than the best. So things like that, are you providing that to the hospital?
Yeah, it's exactly right. You know, I don't know if you guys still have my slide deck up there. I actually have a couple of examples of, those are actual dashboards and it's just a couple of the data points. There's several of them. It gives you the county average, shows your hospital, you know who your hospital is, and you don't get it from me. This comes from the stroke registry, gives it to you. You see everybody else, but it's blinded to you that's in your county. If it's a small county, we'll make the region larger. We try to design it so you can't kind of figure out who everybody is. And you'll see eventually the entire state of Florida average. So you'll be able to see Palm Beach County's average, Broward County's average, Miami-Dade, where you are in the mix. So yes, the tool is designed to be a continuous quality improvement system. But what we eventually would like to see happen from this Florida Stroke Registry is that you see who's doing the best and learn from them.
No,
that's what it should be.
I do have a challenge. This is a little bit maybe to the rest of the panel. My question is, it's a little, not that it's coming here and seeing the penetration of Joint Commission DNV and then have your own certification is just different for me. You know, like that's not the reality we live. So tell me about this, because I think for us is our state never thought about doing this. It's basically either Joint Commission DNV in that sequence, and then where thrombectomy ready centers come into this. So just curious what your thoughts on the Florida designation and how you're going about.
I'll comment on that. I mean, that's the whole attestation.
Yes.
That was put in there to pass a law, an act into a law in 2004. There was no template to follow. So we had to
I
do
see.
that. That was supposed to be a temporary measure and then everybody be certified, but we never got to that point. So that's the problem. So yeah, we were the first, and I think, the best of my knowledge, only in the country that
They had,
self-attested.
but I guess the point is that what is the bar when you create a comprehensive site? Are you looking at where are you getting those guidelines from? You're building that, or is somewhat based between Joint Commission, DNV, or so on?
Well, good question. It started with Brain Attack Coalition, then
Okay.
with the Joint Commission, and then the now 3 or 4, whatever it is, nationally recognized certification
Yes.
agencies to have similar criteria. That's we sort of keep it a little bit vague, not to pin anyone down to one certain certification body.
And maybe I missed, but is there a cost to certification, like a Joint Commission, DNV?
Not in this attestation, no.
No.
$200.
That was, I don't know how else to say it, the motivation to do attestation, because it cost $0.
I see.
That was part of the political push we had in Florida to pass that act.
I have one more for you guys. And I know we create this hot potato, but we need your guys to help solve this hot potato. If you're a cardiologist and you're talking about doing stem intervention, you cannot touch a heart unless if you have done per operator, if I'm not mistaken, 100 coronary angiographies, plus I think it's very specific number of angiographies to do an intervention. I think you have to be doing 300 coronary angiograms to be able to be a STEMI. So flip the coin. Joint Commission remove and put it back because of our pressure. 15 interventions per operator. DNV has no requirement for volume. And one step further, and that's the question for you guys from the EMS perspective. What about if I tell you there is a guy not trained to do this, doing this in a quote unquote comprehensive stroke center? What is the role of the EMS team and directors, knowing that there is I'm gonna change the specialty, but don't wanna pick on anybody. There's an orthopedic surgeon, and that's fictitious, that's not the case, but so you understand. There's an orthopedic surgeon doing thrombectomy. What is the role of EMS on that? Because attestation doesn't check on that. DNV does not check on that. Joint Commission does not check on that.
No.
So,
But DNV.
No.
DNV will check on credentials.
No,
though.
they don't. They do not. If
Right.
you're a body radiologist, it's a fair game. If you are a dermatologist with catheter skills, fair game. Anybody that has quote unquote catheter skills from doing true femoral stents, it counts.
But Ricardo, that you could not get privileges in the hospital unless you're
Maybe.
right. I mean, the point is that you have to have your credentials.
Yeah, that's
But if
exactly
they're,
the
if
point.
they're willing to
Credentials.
sign an attestation, they're going to sign for credentials on that
Right.
intervention.
So that's why I want to hear from
Recommended
Ken and
staff.
from Brad.
They're not going to.
What is the role of EMS on that? Because it is a mass for the population, for the family members. You're going to a comprehensive stroke center. There's nobody trained on that comprehensive center to do that. Where is our duty? And I don't know legally, and that's why we're fighting for law with Charlie there. But how does EMS, Ken, Brad, Charlie, Carl, how does EMS go on that? And maybe Ryan, if you guys have any bright ideas from Rhode Island, how to fight this.
I actually would like to answer that question, and I would like to tell you this. This is all about relationships, and you know, it's the same thing everywhere. Carl came in the room. Look at all the people that came to support him. EMS is by far it's the first and by far the most important link in the stroke chain of survival. And these guys, they are like they're a close family. And as a practitioner, you need to take off your white coat. I say it on Twitter all the time. You got to take off your white coat. You got to go to them.
Get
And you
unicorn shirt.
And you really do have to build relationships, and you have to talk to them. So all this work that's done on a legislative level, sometimes it gets so complex, and then they say, we got to regulate it, so take it to DPH. But inevitably, whether it gets legislated or whether it gets regulated, it's about education and relationships. And so you really need to spend time at the firehouses. This education program, we had a formal education program where we'd actually take an actor And people that do this, Stryker, Medtronic, they have stroke therapy teams that actually do this education. So anyone who's listening that wants to get into this, it's a big job for one or two people.
Yeah.
Leverage relationships with Medtronic and Stryker to get this education done.
We're all for education, and we've done it. Nima is our Energizer bunny going after. Again, every year we try to visit as many, if not all, EMS stations in the city. But they have a hot potato on their hands. That's what I'm asking specifically legislation, because you know what? This is a comprehensive stroke center. So we're talking about bypassing primary, and I'm very thankful we're in that direction. I think we all are. But what about that comprehensive, that is public knowledge, that lost an intervention because he broke his arm and there's nobody covering that call? So
yeah.
What is EMS empowered to do, Ken, on this direction?
Well, it's in a statute, the medical director is responsible for determining the location of the patient is taken. It's not necessarily the closest hospital, it's the most appropriate hospital. It doesn't define further how I determine as an EMS medical director, determine what is the most appropriate, but I'll tell you what I do, and that doesn't necessarily mean every medical director does it this way. We keep a list of hospital capabilities. And so you do an X, you're an X center, whatever it happens to be. Before you get labeled as that, we do a site visit. I go there with my EMS chiefs. You show me what you got, because a lot of these things, like you're pointing out, I don't know if the certification's good. You just write on a piece of paper, you do it. That doesn't mean anything to me. So, I'm good at stepping in political hot water. My folks will tell you that. That's how I had that stroke. They still call that meeting the meeting. They actually do it with the quotes with the CEOs with the bypassing thing. But I don't apologize for it, because I'm here to protect the public interest, and I'm here to protect patients. And as far as I'm concerned, I'm the patient. You guys are the patient. So I don't care what the state says you are. You have to pass our local stuff. So if you've got an orthopedist or a dentist doing brain cath, that's probably not going to pass muster with us.
Yeah.
And we're probably not going to add you to the list.
And that really speaks to the relationship. So you have to have a relationship with the medical director, and where it really gets dicey is Ken is unique in that he's not answering anyone. He can do what's right for patients, but there are a lot of medical directors that will control where triage goes based on their parent organization. So a medical director may be a physician in a certain healthcare organization that wants those patients, and he will feel pressured to basically not allow that field triage.
Absolutely. And that's what we see. I mean, like, we see different hospital systems within the same region. Each one has a representative there. And on that hierarchy, it's very hard to really get to a consensus, because everybody has somewhat of an interest, and really it's challenging to move forward. But I think that on the same line, how much you feel that the connection, having communication tools that you can talk to the physicians in the hospital, as well as, what is your impression of those, not only do an exam, but if you had an imaging or something in your rig, is that something that adds time, is complex, and training? Imagine now you have to train people for do something else. It is getting easier and easier in terms of plug and play, this thing. Do you guys feel that do you have experience with that in any other field? Is there anything that you're familiar with to do extra beyond the care and the transportation of the patient, imaging, everything?
I know at one point we talked about the mobile CT scan here in Jacksonville, and logistically it just did not work. We didn't know how it would be rolled out. In the city of Jacksonville, I don't think it was appropriate for us here. We couldn't find a mission profile for it. Maybe in a rural-based system, I don't know. But then
it's a big city, so you need like 10, right? I mean, we have to have, because that's in Chicago we have 2 now, and the issue that we had is that which neighborhood you're going to deploy this, because everybody else will feel like so the plan, you have to roll this out. If the pilots work, then it would be so, but it has to be a pilot, I think, in the beginning that you have. But I guess I'm asking more like in the training of EMS, is this something that delays or helps? If it would help you determine if that diagnosis is correct with a higher degree of certainty, or it doesn't matter? Because from what you're saying, you're already taking the patient to a comprehensive care. Now, have you had a problem with bypass situation? So that they're full, the hospital's full, then what do you do?
We don't permit diversion or bypass in the city of Jacksonville.
No,
So
okay.
we will, if we announce that we're coming, we're coming. And the hospital does not have the ability to say no.
Is that right? Okay, that's it.
So again,
Amen, amen.
I just started quick into that. You know, again, I'm a paramedic. Okay, so obviously going after the again the needs of our EMS, our transports, and all of that, and definitely, you know, we've had a stroke. Those initiatives and look at those protocols. We're constantly looking at the initiatives of how we can be better with it, and you know, going to these conferences like this and seeing how we can rechange of our methods and all in our county, and hopefully around us, you know, have the right ways of doing it through the legislation and those kind of things and all. We're very hopeful for that. I know we were talking before the fire stations and all, and trying to do the thing again. And then my group, we're always, or at least me, and I'm a stroke stir now into it. You know, I got my pot that I carry around, you know, of it, and keep throwing at them. You know, well, what was this call? You know, how fast? You know, did we move the person and all? And is there different ways of looking at that? If there's a mobile unit and those kind of things, and we keep looking at how we can have some possibilities of doing that. You know, going through the state, Florida, and seeing how we can, you know, pull that together, I think it'd be very, very, very helpful, and be very hopeful with that. So, yeah, and definitely hearing all you guys of what you're, again, let's say we call the products versus the initiatives to doing this. Again, it's just an amazing time to listen to that.
Yeah, I mean,
part of that.
The point for me is that you guys are, I think you said it very well. It's a very key part of the stroke chain. But the earlier we find out that that's coming to our direction, it helps us to also be there for you when you come in, so we can hand off that not to the team that is in the hospital, but actually the team that can do the treatment. And I think that's why the emphasis on not maybe a pre-hospital screening may be one way to call it, but the other is just a better communication to the right people, the team, you know, from the field. And that's what we're trying to get. What is the best way to do? The issue with this is that every time you are aligned to a hospital system, you create one communication that can be seen as a biased way to, here it seems that you guys are ripe to create a system that you have a perfect communication from the field to actually do interventionalists, not only in a stroke neurology, not only the ER team or whoever is receiving the patient in the hospital, so that the teams can be actually waiting for you when you come in. This is not always simple with traffic and people not having sirens in their cars to have a whole team come in and be waiting for you in the ER in off hours. So then comes the other idea, which is have in-house teams. I don't know we're there yet, but
I think we're on the right track. I mean, I think the whole point of this Florida registry is actually, and Peter Antebi, who's a close friend of mine and Ken's, is sort of behind it, is that we talk about this stroke chain of survival as this linear thing. Yeah. And the visual is that they are trying to link the neurointerventionalist at the end of that stroke chain of survival with EMS. So that's the whole goal. So you're exactly right. We do want to create these relationships, and if it's technology, whatever, but there needs to be a union, direct union with EMS.
So one of the things that Baptist and JFRD did was the LAMS coordination, and so that's all part of our pre-notification. So Baptist, based on the onset time and the LAMS score, provides a mechanism for pre-notification.
So how do you guys hear about it?
Just to echo what Dr. Elias said, we have a great relationship with our EMS, and they were very open to LAMS, and we came up with pre-notification. So now they send us a pre-notification, so we know the patient's coming before even they get there. So those are all very helpful.
Which tool do you use for that?
LAMS. So we have LAMS and we have algorithm.
That's a clinical exam, but then you get a page or
right. So EMS says I have a LAMS 4 coming, ETA is X. We have an algorithm. We look at the diagram. If the LAMS is 4, patient's potential thrombectomy or TPA candidate, that's a level 1. we have a secure text messaging that goes through Cortex, through all the stroke provider, the ICU team, and the nurse practitioner who respond first, and then
And I'm sorry, what is the name of the product that does the
right
name?
now we use Cortex.
Cortex.
Yeah,
Okay.
it's HIPAA compliant.
And they have Wernicke and Broca's, and the Cortex is the whole system.
Yeah, but no, so everybody gets that. But just to echo what you guys said, I think one thing it's clear is stroke is new, it's challenging treatment. It should be just like trauma, and I think in a few years from now we're going to sit back and say, the way we treat trauma is now where we're going to treat stroke in the near future. And
But they have in-house teams.
yes, well we have 24/7 coverage, as you know.
Yeah, no, but not in-house. Amito.
And that's, we definitely have seen that from the EMS perspective, with the pre-notification and, the stroke alert, the emergency department is waiting for that patient.
We have a
Immediately to CAT scan.
in our Baptist, we have a 24/7 nurse practitioner present in
Yeah.
ICU who respond to any code stroke. So
Yeah.
we do have that available. For the sake of time, I know we have some EMS guys here. I must say that I've visited many EMS stations, and overall our EMS team does a great job. Everybody's very passionate, and we're all trying to do the right thing. So for the sake of time, unless anybody else have any other comments,
I just wanted to say one other thing, and I apologize, but that Florida registry, are they recording whether CTA is done on all code strokes?
So we have the ability to put any data point we want into that thing. And that's part of the reason why it took so long to develop, because we were sort of debating what needs to be in there, what doesn't need to be in there, and we want to do it in an automated manner.
I only say that because if we're going to react and transform systems of care, we need to know what that denominator is. And unless we're getting CTAs on all code strokes, we're not going to know how many patients are out there, how many we're missing.
Yeah.
So just for everyone in the room, we really need to be getting CT angiography on all the code strokes. And if a hospital's not doing it, they have no business accepting a stroke patient, as far as that.
It's the get with the guidelines data set, and it's refined from that. So the folks that are in the hospitals may know if that know the answer more than I would, because I don't know if they plug in.
Just to be aware.
Okay, guys, we're the only thing between you and the next beer. So I thank you again, all of you. Tomorrow we're going to be a little bit more generous. So we're going to start at 8 a.m. With a breakfast at 7:30. So I hope I see everybody bright and early.
Yeah, I'm very impressed.
Thank you, everybody.
Thank you, guys.